Lens-induced glaucoma. The lens can play a role in the development of open-angle and angle-closure glaucoma. Lens-induced OAGs are divided into three clinical entities: phacolytic glaucoma, lens particle glaucoma, phacoantigenic glaucoma. Lens-induced angle-closure glaucomas include phacomorphic glaucoma and ectopia lentis and are discussed in Chapter 10. Phacolytic glaucoma. Phacolytic glaucoma is an inflammatory glaucoma caused by the leakage of high molecular weight lens protein through microscopic openings in the lens capsule of a mature or hypermature cataract, Fig. 8 to 9, that subsequently obstructs the trabecular meshwork. As the lens ages, its protein composition changes, with an increased concentration of high molecular weight lens proteins. Elevated IOP occurs as a result of obstruction of the trabecular meshwork by these high molecular weight proteins, lens-laden macrophages, and other inflammatory debris. Individuals with phacolytic glaucoma are usually older patients with a history of poor vision. They have a sudden onset of pain, conjunctival hyperemia, and worsening vision. Examination reveals markedly elevated IOP, microcystic corneal edema, prominent cell and flare reaction without keratic precipitates, KPs, an open anterior chamber angle, and a mature or hypermature cataract, Fig. 8 to 10. The lack of KPs helps distinguish phacolytic glaucoma from phacoantigenic glaucoma. Cellular debris may be seen layered in the anterior chamber angle, and a pseudohypopion may be present. Large white particles, clumps of lens protein, may also be present in the anterior chamber. The anterior lens capsule of the Figure 8 to 9. Characteristic appearance of hypermature cataract with wrinkling of the anterior lens capsule, which results from loss of cortical volume. Extensive posterior synechiae are present, which suggests previous inflammation. Mature or hypermature, Morganian, cataract may exhibit wrinkling, which represents loss of volume and the release of lens material, see Fig. 8 to 9. Ocular hypotensive medications may be necessary to reduce the IOP, however, definitive therapy requires cataract extraction. Lens particle glaucoma. In lens particle glaucoma, retention of lens material in the eye after cataract extraction, capsulotomy, or ocular trauma results in obstruction of the trabecular meshwork. The severity of IOP elevation depends on the quantity of lens material released, the degree of inflammation, the ability of the trabecular meshwork to clear the lens material, and the functional status of the ciliary body, which is often altered after surgery or trauma. Lens particle glaucoma usually occurs within weeks of the initial surgery or trauma, but it may occur months or years later. Clinical findings include cortical material in the anterior chamber, elevated IOP, moderate anterior chamber reaction, microcystic corneal edema, and, with time, posterior synechiae and peripheral anterior synechiae, PAS. Medical therapy may be needed to reduce the IOP while the residual lens material resorbs. Appropriate therapy includes medications to decrease aqueous formation, mydriatics to inhibit posterior synechiae formation, and topical corticosteroids to reduce inflammation. If the IOP cannot be controlled, surgical removal of the lens material may be necessary. Phacoantigenic glaucoma. Phacoantigenic glaucoma, previously known as phavanaphylaxis, is a rare condition in which patients become sensitized to their own lens protein after surgery or penetrating trauma, resulting in a granulomatous inflammation. The clinical picture is quite varied, but most patients present with a moderate anterior chamber reaction with KPs on both the corneal endothelium and the anterior lens surface. In addition, a low-grade vitritis, posterior synechiae, PAS, and residual lens material in the anterior chamber may be present. Glaucomatous optic neuropathy may occur, but it is not common in eyes with phacoantigenic glaucoma. Initiation of topical corticosteroids and aqueous suppressants are recommended. Figure 8 to 10. Phacolytic glaucoma. The typical presentation of phacolytic glaucoma is conjunctival hyperemia, microcystic corneal edema, mature cataract, and prominent anterior chamber reaction, as shown in this photograph. Note the lens protein deposits on the endothelium and layering in the angle, creating a pseudohypopyon. To reduce the inflammation and IOP, the residual lens material will likely need to be removed once the inflammation is controlled. Intraocular tumors. A variety of tumors can cause unilateral glaucoma. Many of the tumors described in this section are also discussed in BCSC Section 4, Ophthalmic Pathology and Intraocular Tumors. Depending on the size, type, and location of the tumor, IOP elevation can result from several different ENT mechanisms, including direct tumor invasion of the anterior chamber angle closure resulting from rotation of the ciliary body or from anterior displacement of the lens iris interface, see Chapter 10, intraocular hemorrhage, neovascularization of the angle, deposition of tumor cells, inflammatory cells, and cellular debris within the trabecular meshwork. Choroidal and retinal tumors typically cause a secondary angle closure glaucoma by the anterior displacement of the lens iris diaphragm, which results in closure of the anterior chamber angle. Posterior synechiae may develop as a result of inflammation of necrotic tumors. They exacerbate angle closure through a pupillary block mechanism. Choroidal melanomas, medulloepitheliomas, and retinoblastomas may also cause neovascularization of the angle, which can result in angle closure. Neovascularization of the angle may also occur after radiation therapy for intraocular tumors. The most common cause of IOP elevation associated with primary or metastatic tumors of the ciliary body is direct invasion of the anterior chamber angle. This can be exacerbated by anterior segment hemorrhage and inflammation, which further obstruct aqueous outflow. Necrotic tumor and tumor-laden macrophages may cause obstruction of the trabecular meshwork and result in a secondary OAG. Tumors causing a secondary glaucoma in adults include uveal melanoma and melanocytoma, Figs 8 to 11, 8 to 12, metastatic carcinoma, lymphoma, and leukemia. In children, tumors associated with glaucoma include retinoblastoma, juvenile xanthogranuloma, and medulloepithelioma.